Good morning, everybody. Welcome to the final lecture series of the year. Today, we are talking about something a lot of people don't know about, like survivorship. Today, we have Siavash Azarnia, MD, who has been in the palliative care department at UI Health since September of 2022. So he's an early career physician. He previously worked as a hospitalist at Northwestern Medicine and trained in hospice and palliative medicine at the University of Wisconsin in Madison. Savash's clinical interests are early palliative care for all chronic conditions, addiction, and antibiotic stewardship. But today, he will speak on palliative care in cancer survivors. So, Savash, whenever you're ready.
Thank you so much, Dr. Mance. Thank you for that wonderful intro. Again, I'm Siavash Azarnia. I'm one of the palliative care faculty. And thank you so much for having me. I really appreciate the opportunity to speak to all of you. I'll be talking a little bit today about how palliative care can be helpful for cancer survivors. So let's begin. I don't have any disclosures yet to admit to. So just some quick objectives. I thought it would be a good idea to start off by reviewing palliative care for those who need a little bit of a refresher. I find that other providers know about palliative care, but when asked to explain what it is or what we do, they're not so sure or just are, sometimes just incorrect, calling us hospice or something like that. So reviewing it makes sense. I'll then do a quick review of what I understand of survivorship, being sensitive to the fact that I'm very new to this and only recently learned properly what survivorship is. And I'm really reviewing survivorship in the hopes that I can highlight some of the important parts of survivorship that I feel link well with palliative care, which then leads to the third objective, which will be a little bit about how palliative care can be helpful for survivorship patients. And finally, just a little bit about future directions. I wanted to just do a quick slide to introduce our team. We have a really awesome team here at UIC. Amazing APRNs, Miriam Khadija, Dr. Minty Shah, who's a brand new addition to our team and has just been fantastic from day one. We have two wonderful, incredible social workers who we lean on heavily for their expertise. And of course, we have our dedicated palliative chaplain, Lauren. Oh, sorry. So what is palliative care? It depends on who I'm talking to, so patients or providers, but in general, it is the interdisciplinary supportive management of patients with serious illness. I say supportive because I'm not just, I'm not adjusting people's chemo regimens or messing around with their goal-directed medical therapy, but I can be managing just about everything else related to the serious illness. It is not restricted to just patients, but it's also supportive care to the families, their caregivers, and at times other providers as well. In palliative care, we talk a lot about domains of care. There's about 8 of them that we refer to. So I think it makes sense to quickly review what those are. These include structure and process of care, the physical aspects of care, so the relieving of symptoms and improving or maintaining a functional status if that's important to quality of life for the patient. Psychological and psychiatric aspects of care, a domain where we lean heavily on our social workers and health psychologists for. Social aspects of care, so addressing the environmental and social factors that affect patients and families functioning. Spiritual and religious aspects of care, where we are lucky to have our chaplains assist with. Cultural aspects of care, so being sensitive to the needs of others who may culturally feel different about what a quality of life means to them. Care of patients near the end of life, where we employ the use of a service like hospice, which falls under the umbrella of palliative care, but is not, what is palliative care. And ethical and legal aspects of care, which can be as simple as making sure a patient has a designated healthcare power of attorney, or identifying a legal surrogate to make decisions for them if they're unable to make decisions for themselves. And of course, filling out a POLST form, so deciding whether or not somebody is DNR or full code. Studies have shown that through the early integration of palliative care can help improve quality of life for family and the actual patients themselves. There was a landmark study with lung cancer patients that received early palliative care that showed that they actually lived longer with the ones who received palliative care early. But I actually don't love to point that out because I tend to focus on making people's lives better because that's the end result to me that matters the most when I'm working with my patients. So here are some of the services we can provide to our patients on every visit. I would say depending on the setting, which can become more or less prominent in depending on like the setting. Each of these can become more or less prominent, such as in the inpatient setting. What I tend to see is goals of care. Right, people are really sick, and decisions need to be made about how to care for them properly. That is in line with their values and their goals. And so that's what I tend to see on the inpatient setting, although we do plenty of symptom management as well. But then when people come to see me in the outpatient setting, almost always it starts out with just symptom management. And then slowly, as time builds, as the course of their disease continues, my care begins to reflect more of the goals, advanced care planning, spiritual and coping support, those types of things. So the question then becomes, who should get palliative care? I hear this from a lot of providers who say stuff like, I don't know if they're ready to go full palliative yet, which I still, as yet, don't know what that means, although I've heard that plenty of times. Or do they really think they've gone that far? And the answer really is anyone with a life-limiting illness. I also encourage providers who are on the fence to ask themselves, would I be surprised if this patient died in the next year? If you answer no to that question, then the patient should probably be co-managed with palliative care to at least address some of the serious illness needs they have. And the perk of this is that, if that's not enough of a selling point, is that we can take on a whole lot of things that other physicians try to run away from, right? So like difficult conversations with families and patients. People don't like to do that, but we go headfirst into those types of situations. Or managing high-dose opioids for complex serious illness-related pain. Another thing that I remember as a hospitalist and as a trainee, internal medicine trainee, I would just, do whatever I could to not prescribe people opioids. And that's something that is just bread and butter palliative care. So I want to include this really nice diagram because A, I like it, and B, I think it does a really eloquent job explaining how palliative care can be beneficial from the time of diagnosis, slowly increasing in prominence until a patient reaches the point of end-of-life care. I'm also happy that it includes bereavement, so to remind us that hospice care keeps working for the family even after the patient has died. Because again, in palliative care, we recognize that patients aren't the only ones experiencing this illness. It's the people and the infrastructure around them. So the bottom line is we're here for patients in areas where other providers don't have time for, and frankly, sometimes don't even want to deal with. We make a commitment to a patient first guiding principle, sort of our North Star, if you will, when it comes to caring for our patients, even at a great emotional and professional toll to us. Rarely do I come across people who go into this field unless they are committed to the cause of providing excellent supportive care. So this leads us to a little bit about survivorship. So I will admit that I'm a little new to this. And so Dr. Bance, if you notice I'm completely botching what survivorship is, then you have my permission to shush me at any point and correct me. But I'll start off by saying, for me, coming into this lecture, I was in line with the old school. I believe that to be a cancer survivor, a patient had to be disease-free for 5 years before achieving that status. Obviously, since then, I've learned that the definition has been broadened to include anyone from the time of diagnosis and throughout the lifespan, also including their loved ones and caregivers who also bear the burden of this journey that no one wants to take. Broadening this definition and recognizing these patients is important for the simple fact that we're getting better at diagnosing, treating, and monitoring cancers. And as a result, people are living longer. Now, voila, right? I was surprised, but also not surprised to hear that 1 in 20 Americans would fall under this definition. The reality is that those patients have unique needs to the complete upheaval of their lives, going from someone without cancer to then becoming a cancer survivor. And so the need to address those needs are just as important to addressing the cancer itself. So just like I spoke a little bit about the domains of palliative care, I thought it would make sense to use a similar way of describing the tenets of cancer survivorship. So I'll just read them off a little bit. So surveillance for recurrence and screening for secondary primary cancers, long-term and late effects of cancer treatments, health promotion, aka lifestyle modifications, promotion of psychological well-being, care coordination and communication. And as you can see, 3 out of these 5 domains right off the bat, I might as well be talking about palliative care. And thus I believe our field can be really beneficial to address these unique needs that survivors have.
Siavash, you pretty much hit it on the head. Just, again, yeah, that very comprehensive aspect of what we do, right?
Yes.
I would extend that psychological support to, supporting barriers to care and everything a little bit more broadly, but it does overlap quite a bit.
That's nice. Perfect. Perfect. Thank you, Dr. Metz. And I thought it'd be a really good idea to show this diagram on here as well, just because I saw it in multiple papers that I evaluated in regards to cancer survivorship. It's really similar to the information that I was sharing with that palliative care continuum diagram that I showed earlier, with the exception of instead of being kind of a cool trapezoid, it's kind of a fun squiggly line. But I thought it was rather strikingly similar. It just showed me how much these two disciplines have in common. And so without stating the obvious, these two fields mesh really well. They both emphasize the patient and what they're experiencing as the central focus of their care. Both are, by necessity, multidisciplinary in nature. And yet, despite this obvious kinship between these two fields, there is limited data in the literature showing how much they can work together. I think, when I was doing like a lit search, there was, maybe like 4 or 5 papers that I, found that actually talked about it. So I thought for the purpose of this talk to speak a little bit about the different aspects of survivorship care that I think in current palliative care can be really beneficial. The first and most obvious is with symptom management. Cancer patients develop all kinds of symptoms in relation to their diagnosis. Pain alone can be from the plethora of cancer-associated causes, whether from visceral or somatic pain that's induced by the cancer itself, or the treatments that people undergo, such as the side effects of radiation surgery, chemotherapy, etc. And these symptoms can persist for years, even if a patient is considered cured. I have to admit that for patients who have been cured of their cancer, there's a little bit of a debate in palliative care as to whether or not they should still be managed by palliative care for their pain, or because their pain appears to be more chronic, whether or not they should be seeing a chronic pain specialist. As we always inform people in palliative care, we're not pain specialists, even though we get good training in pain care. We didn't our fellowship wasn't 100% just pain management. But that's a debate that's ongoing in the field, and hopefully we can there will be more guidance on that in the future. These other symptoms listed, just to list a few, are common issues I see in our patients that we can treat and help with to improve their survivorship experience and to make a difference in these individuals' lives. Things as simple as fatigue and not being able to be around their family or be present for their families, figuring out ways to help them conserve their energy and kind of use those, energy dollars, so to speak, at that right moment to maximize the time that they spend with their loved ones or to do things that they find pleasurable, is something that is a very normal occurrence for me in my visits with my patients. Although I admit that I'm not a certified mental health professional, we in palliative care consider it our duty to provide primary mental health care to our patients who develop psychiatric or psychological maladies that can develop due to their serious illness that people live with. I'm sure I'm preaching to the choir here when I say that these conditions in the general population, certainly with cancer patients, are underdiagnosed and undertreated. This is where the multidisciplinary support that we have in our teams is really needed, as we can get, the providers can provide the medications, our psychosocial support can be provided by our social workers, and spiritual distress can be addressed by our chaplains. And then if, even if on bigger teams, our team doesn't have this, but on bigger teams where they have health psychologists, those individuals can be so beneficial to be able to help survivors, deal with the trauma of having this illness. And then care coordination and communication. Communication between disciplines is just a normal everyday part of what being a palliative provider is. Oftentimes I feel like I'm the glue between the different fields and helping kind of piece together for the patient and their families, what's happening. Because maybe they're getting information from one provider and then a different provider, and they're having difficulty kind of putting it all together. And that's where I can be really helpful, because I'm internal medicine trained and familiar with the medicine side of things. And so, and yet I've also had the training in communication that my fellowship provided. And so I can kind of look at everything that's happening between the different disciplines, and then be able to present a comprehensive story that makes sense to patients and their families. It's not unusual for me to be contacted by patients' PCPs to speak about what's happening from the cancer front, which I find telling because sometimes they don't even call the oncologist, they call me instead. Just like how a surgeon is skilled at operating in the OR, communication between disciplines, patients, and families is our specialized skill and can help survivors navigate their illness. So future directions. So where do we go from here? And kind of the bottom line is we need more people interested in this and wanting to look into it and commit funds and research money to looking into it more. As I mentioned earlier, my literature review kind of barely showed anything, on my radar. And I find that to be unusual because, just given from what we've talked about in this talk so far, there's really a lot of similarities between these two fields where there's a lot of overlap, and I feel like we can help each other to be able to help the patients live the best lives that they can, given what they're dealing with. So hopefully there can be more interest in funding research that looks at integrating palliative care and survivorship so that it is beneficial for cancer centers to invest in this type of synergistic care. We want them to feel like there's both an incentive from the patient front, but also maybe a financial incentive to provide this type of care early for survivors, so that they live their best lives and are able to get the care that they need when they want based on their goals and values. Once that is done, kind of figuring out how to get Medicare and Medicaid to recognize this and to support it by paying just as much for this as they do for, say like for certain types of procedures. I think that will be our ultimate goal, and certainly in palliative care, where we put a lot into our patients' care and a lot of our emotions and or our emotional well-being into our patients and providing them the care that we do. Unfortunately, from a payer standpoint, it's just not recognized, and I think being able to change that by advocating for what we do and how difficult it is, so that they recognize that what we do is just as difficult as what a surgeon does in the operating room, I think will be one of our goals in the future. But that's a fight for another day. A little bit of a quick lecture, but I want to kind of leave the floor open for any questions.
Thank you, Siavash. It's definitely necessary work. It sounds a lot like treatment of cancer survivors going forward is going to lean a lot more on survivorship and palliative care to take care of these patients psychosocially, biophysically, everything, all in one in our decided professions. I have a lot of questions, but does anyone else have anything they want to ask first? Anything for Siavash? Dr.
I
Jim?
do.
Oh, I know you do, Betty. I knew you would. Did you have something, Dr. Jimbo? You were the first one to come on. He may just be off mute. So yeah, Betty, what ages does palliative care address and how does that care change?
All ages. So I'm a huge proponent of palliative care starting at diagnosis for cancer patients, all cancer patients. Yeah, I've never thought about it being in survivorship until today. Isn't that crazy? So thank you, both of you, for that. I know. And I often say that palliative care needs its own marketing firm because yes, indeed, even healthcare professionals don't understand what it is. So great presentation today. I'm so glad to hear you are a young in your career and you have this much knowledge about palliative care. And I also want to say another thing that I didn't know until you talked today too, and it makes so much sense for cancer patients, is that palliative care has longer appointment times.
Mm-hmm. Absolutely.
And
my initial appointments are an hour long, so.
I mean, think about that for, disease understanding, improving communication, feeling like you can ask your doc,
Mm-hmm.
So thank you for this. Very enlightening for me today. I really appreciate this presentation today. Thanks.
Thank you.
Yeah, there's a reason please contact you. So,
I'm sorry I didn't respond earlier.
go ahead, Dr. Okay.
Yeah, no, this was a great presentation. Thank you. And family medicine tradition have had folks who did additional training in hospice and palliative care. In fact, one of our star residents this year matched in his top choice in
Javier?
hospice. Yes.
Yeah,
That's correct.
I wrote a letter of recommendation for him.
Awesome. I did too. So I'm very happy that he matched it at his number one choice. So
Where's he
very
going?
happy about that. Rush Cook County.
Good for
That was-
him.
that was his top
I'll
choice.
text him and congratulate
Yeah,
him.
that
That's
was
awesome.
his top choice. So that's really great. And yeah, so initially when hospice and palliative care came about, particularly in the palliative care, I had some conflicting thoughts because as a family physician, primary care physician, I always thought about those are the kind of things that I should be discussing with my patients. But at the same time, just as Dr. Azarnia has said, the expertise that the palliative care specialist can bring is the communication, the time, and the knowledge about the resources. And I think it's also important to know that it's not terminal care. Palliative care is not necessarily terminal care.
No.
And I think that's probably the biggest misconception that many of the clinicians have. And also, as we make the referral, I think it's very important for the patients to know, we're kind of making this referral not because we think that you're going to die in 6 months. It's really more about these are specialists that can really look at your quality of life and making sure that that's maximized, and they have expertise to do that, and that's why I wanted to work with them as a team for you as a patient. So I think and certainly in both outpatient and inpatient, we have very much benefited from the care and the service. So thank you.
Yeah, absolutely. Yeah, we're family medicine is one of the main pools that we draw from for providing us. I think IM and FM are the two biggest providers of palliative care providers. There's a lot of love between all those fields.
Yeah, and I can certainly understand because the reason we chose, I think, often the primary care field, like general internal medicine and family medicine, is because we like to communicate with the patients. But unfortunately, in this fee-for-service environment, it's getting harder and harder to do that, to have appropriate time to do it. And it's great that within the consultation context of the palliative care, that more time is afforded. And I think because that is really necessary, I think, to spend time with the patient, to make sure the patient understands everything that is being offered and what it means. And I think it's just a great service. So thank you.
Thank you.
Yeah, I would agree. We in survivorship also have the 30-60 model. So it really allows you to build that relationship a lot closer with those patients, to be able to talk about those things that matter to the patient and dive deep into those medical issues that are really complex. So that extra time is necessary. Thank you for your comments, Dr. Jimbo. Anyone else have any other comments, or should I just ask my multiple questions? Well, first I was wondering, you talked about opioids, of course, being a huge thing. I know we used to rely heavily on our previous palliative care doc, and the department is now flourishing and getting new providers since his departure. And we built the work group, the Coleman group. Does that still exist? Are you part of that?
I'm not a part of that, but Khadija, one of our excellent nurse practitioners, is a part of it.
Yeah. So for anyone here that doesn't know, the Coleman group is a multidisciplinary group, of course, of doctors and NPs and other people in addiction medicine that work with patients, especially cancer survivors who have chronic pain needs, and that are on opioids and going on and off, or potentially abuse, but just a lot of patients who are just chronically on it and just have issues arise due to that. So definitely a necessary place for palliative care. Tamara, you keep popping up. Do you have something you want to contribute?
No, sorry.
I just wanted to make sure. Yes, you also mentioned sexual dysfunction being a palliative care issue. What do you encounter? Like, what's your primary discussion with sexual dysfunction with patients?
Yeah, I tend to notice it with my male patients who it usually comes about when they are talking to me about how maybe they describe themselves as quote unquote the man in the family and or at work, and they had this identity of being this powerful, strong person, at least in their minds, and all of a sudden now they're relying on others for their care, and that's really hard for them. And so it's kind of a natural next step for me to be like, and has this affected you from a sexual standpoint? And sometimes, that's too far, and they say, no, I don't want to talk about that, and I respect that. But sometimes they do, and obviously we have good medications for that. So I kind of try to take the shame out of it and just explain to them that it's just a normal, it has nothing to say to you about who you are or who you are as a person or as a man, but it is something that is common, and it's almost expected when you're dealing with a lot of other things. And then I take the shame out of using medications to help if that's something that, because I think for me, maintaining the important relationships in my patients' lives is crucial to them being able to live as good of a life as possible and to be able to face the treatments that they're dealing with and any other aspects of the cancer that they have to face. And so that also means making sure that them and their spouse are able to engage in activities that keep their romance alive. So
yeah, relationships are really important.
Exactly.
Definitely. That's so interesting to talk more about. It comes up in males because in survivorship clinic, we occasionally will see that. We see a lot more females though, and not even identifying or realizing that sexual health is an issue more so for survivors too. I don't know if anyone in our clinic has anything to comment on that. There is a new GW course. It's a CME. I don't know the full CME of it, of sexual health in cancer survivor.
That's really interesting.
So I will forward some information out about that. Oh, thanks, Betty, for putting it in the chat. Being all over it as usual. So this makes me think also of disability in cancer survivors because it's an identity issue. And so patients, saying I'm the man, I should be able to do this and provide. And it's also a similar kind of parallel with becoming disabled or realizing you're disabled.
Yeah.
And so that's something we had to talk a couple months ago with Susan Magacy, who's doing some research on an app. I should hook the two of you up. And she talks to patients about disability. Is that something that you have discussions with patients about as well?
I do, but mostly in the sense of our psychosocial assessments. It's just something that I note and I talk them through. And then provide resources if necessary to help them address those. So I'm married to an occupational therapist, so or former occupational therapist, so I'm well versed of being able to adapt your surroundings to a new reality that people have, and so linking them with these various specialties that might be able to assist, at least adjusting their new normal. is definitely part of my care. It's not unusual for me to kind of address those needs. Obviously, I'm not a therapist myself, and so I can't always help with being able to know exactly what to do, but at least being able to direct them in the right direction.
That's a
We're
great
trying to get I would love to get occupational therapists into palliative care as well, because I think there's a lot of there's a lot of overlap between occupational therapy and palliative care, and probably also survivorship, that I think would be really helpful.
Yeah, it sounds like a network we need to take advantage of. And so I'm going to talk a little bit more about that in a little bit. Also, psychosocial issues about depression, anxiety, PTSD. What else did you mention? Fear of recurrence, return to work, financial issues, all mentally taxing for patients. And definitely something that we address every single clinic in survivorship and with our patients regularly. I'm sure you do as well.
Yeah.
Cancer patient. Oh, sorry.
I had a really, as an intern, I had a really profound experience with actually, no, I was a second-year resident, so I was a senior resident at the time, but I had a really profound experience with an AML patient who was in the hospital for a month plus, getting treatment. And I remember, and I developed a really great relationship with him and his family. And I remember we were sitting down one day, and he just said to me, he's like, Doc, everything's so different now. It's just like everything that I thought mattered before, I just don't care about it anymore. And now my life is so like, I don't even recognize who I was before. And I remember hearing that, and it's kind of reminds me of how, of how just life altering these diagnoses can be for our patients, and how it completely just turns their world upside down, and how just being able to recognize that, and then to be able to provide them resources or provide them care to address that, I think is just is so necessary to be able to address their illness. Because if they're in that headspace, then it's going to be hard to get them to make their appointments, get more treatments, make sure they're taking their medications on time, those types of things. So
Wow, thank you for sharing that. That's so impactful to hear, and I might speak to you more about that. I am speaking next week for the Illinois Department of Public Health on cancer and mental health, along with some other speakers, including a cancer survivor and someone from a community organization. So I will send out details about that talk later as well. And just getting back to something Betty said, palliative care needs its own marketing team. So how do we encourage folks to utilize this service and make referrals, and how do we get the word out?
It's just continuing education. I have found, I have to say, the younger generation of physicians are learning early in their career trajectory that what palliative care is. We have a lot of learners. I mean, on a normal day, I'll have anywhere from 4 to 5 learners in the palliative care office. And so we are providing them that education, and so that as they rise and they become physicians, full-fledged physicians themselves, they'll recognize what we actually are, and begin to refer patients to us, because they understand what everybody, like I said, I'm preaching to the choir here. They understand that we're not just for terminal end of life situations. We're there for people at the beginning of their serious illness. It might be limited, but as time progresses, our role might become more prominent, and those younger physicians are recognizing that. And I think that's something that makes me really happy. In terms of just I try to provide education to patients, because their families, when I say I'm palliative care, they're like, oh, like hospice. And so I just say I provide them that education. So it's just one patient at a time, one family at a time. I don't have the resources to, put palliative care on billboards or something like that saying what we actually do.
Wouldn't
I
that
wish
be
I
nice, right?
Yeah. Have you thought about palliative care today?
We need a good hashtag.
Yeah, there you
Everyone
go.
needs
Uh-huh.
about it. Yeah, Betty, we need to noodle on this a little bit and see how we can spread this word and everything. And I completely agree. Do you talk to the oncology fellows here?
Yes.
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 Yeah, I talk to them about survivorship every year too. So it's
They
important.
rotate with us too. So
And they have no idea what survivorship is, as I'm pretty sure palliative care, like I talked to them, no one knows how to define this correctly. So
even me as of a few months ago. So
oh, it's a hard, like when it's something, it's not quite intangible, right? There is a definition to it, but it's hard to create that picture for people. Both.
I'm sorry for interrupting, but my pragmatic viewpoint on this, because I'm not a clinician, I just work in this oncology space, is that if people were given it at diagnosis, right? If it was offered, and you said it's you might not offer a lot at the beginning. If somebody who's newly diagnosed, no matter what their age, had an hour with a clinician who knows about cancer and knows about upcoming side effects and knows about the long-term effects and knows the seriousness of the disease, an hour at diagnosis would make that person understand palliative care. And the clinicians, the oncology team would also benefit because they have a more educated patient. We just got to get over that hump. It's like with the diagnosis of cancer needs to be an automatic referral to palliative care if a site has palliative care.
Yeah.
VK, did you hear that? I saw him just join because we were gonna talk briefly about a program, clinical trial that we're running. And I know he was just connecting. So definitely trigger referrals for palliative care for cancer patients would be a great idea, so that everyone, and that would just help all providers to learn more about it too, like, because as they're training, as they're going through this, we refer everyone to palliative care. Well, create that link. So I think that's probably a great idea to go with that.
So Deb, this is the perfect segue for the slides I'm going to present.
Hey, we have VK Gotti, the Deputy Director of Cancer at UI Health, who's going to tell us about a program and about kind of how to pull this into our clinics and how we are working in kind of a different way. Please tell us about this program, VK.
Sure. So one apology, I just landed, and so I made a pit stop at a coffee shop to present. So I apologize for any background noise. I'm using noise canceling technology, hopefully it's clear. So this is a study that's actually open here. It's been open for about 6 months now. And as you can see at this site, it's Pam, who we all adore and love, as well as myself as the main PIs. And then Angelina, who's on this Zoom, is helping in the capacity of a associate research coordinator. The main study is actually supported by an oral grant from a dear friend and former colleague of mine, Fran Lewis, who, if you guys know Fran, she's super duper passionate about this space, but also basically it's a program TPC to teach you.
I think we're getting everything you're saying, VK.
Sorry, say that again.
I'm not quite picking up everything you're saying. Can you repeat that?
Sure. ECPC. Can you hear that now?
Yeah, it's a little bit better.
I'll do this. ECPC is a program that was developed essentially for parents of young children who are dying from their cancer. And the other requirement is that there's a healthy other parent or parent-like figure available for that child. This is a multi-site study, of which we're one of the main sites. There's actually 8 sites now, and you see some of the ones listed down below there that are active in recruiting. And essentially, the problem, of course, is that we want to address the grief and parents who are going through this, but also to make sure that the children are okay. So I won't read you these aims, but the first is really focus on the efficacy of this intervention. And the second is to look at the impact on the children whose parents actually died during participation. The criteria are simple. Basically, anybody with, quote, unincurable cancer and solid tumors is generally stage 4 disease. And for patients with hematologic malignancies, it's typically defined as having had treatment failures from 2 or more lines of therapy, with less than a 50% chance of cure in any setting. English is the main language here, and we've been asked repeatedly about why not Spanish. It turns out to do this culturally in a competent way that would have required a lot more resources than were available on this grant. So they just really, unfortunately, you can see the age they're targeting is that there must be a child between age 5 and 17 at home, living at least 50% of the time with the ill parent, concurrent with the residential non-parent or parent surrogate. And by parent surrogate, we could be a grandparent, could be a foster parent, etc. This is just an outline of the intervention. So there's a control group with basically light touches and some data collection. And on the right side, there's, you see, every 2 weeks, a structured intervention that's delivered by the University of Washington team. So essentially, we identify patients, make sure they're clearly candidates, and then they're passed on to the University of Washington team who delivers these interventions by telephone. And you can see the time commitment on the right. And then the topics that will be discussed are shown kind of down below, just high level, kind of by the titles, you can kind of assume what's going to be discussed in this section. So the methods for recruiting, previously loosey-goosey, anything goes. We're sending out opt-out letters, telephone calls, see a patient in clinic that's a candidate, we pass them on. Then the UW team would call those patients. Patients can self-referral if they hear about this as a study, either at our site or anywhere in Chicago, in the state, et cetera. If they hear about it and want to be part of it, they can just reach out to us and we can do the handoff. And then obviously we're doing these direct patient recruitments in our clinics. We've already canvassed some other locations, such as the palliative care team, and coming to you as a survivorship team. If you're seeing these patients who are facing these decisions, we'd appreciate the referrals and that as well. Once we know about this, we'll confirm that they meet these criteria. And you can see, one of the things that I find challenging is that even though I have some young patients, oftentimes I actually have older children, 18 and greater. So it's been hard to find patients, just because I think the way our patient population tends to shift early in terms of childbearing, this has become a challenge, especially for me as a breast cancer doctor. I've not seen as much. However, there's enough children out there that are being raised by, say, a grandparent, and so that becomes a possibility as well. So that's really just a high-level overview. The intervention is really to target the wellness of these children and the family unit. And then, of course, when a patient passes, to kind of look at the impact on those survivors. So happy to answer some questions if you want. We've been enrolling. I won't say it's brisk. It's been pretty slow, but that's actually been the case at all the sites. So there's plenty of capacity. That's part of the rationale for us reaching out and trying to canvas other teams and groups within our university setting where these patients might be being seen, but not necessarily being referred.
Great, thank you, BK. Siavash, do you see some patients that you think might fit these criteria, or maybe we can present? Did we present this to palliative care yet, BK? At UIS?
I think it has been, but it may have been a while. Yeah,
it has been. I presented to one patient who unfortunately has since died. But I'll keep it in mind. There's a couple other patients I have in mind who I think would benefit from it, who I'll have follow-up visits for. So I'll make a note to.
And
give them
just
the
for
information.
all of you guys, Fran Lewis is one of the best human beings I've ever known in my life, and she's been very, very open about engaging, writing papers, working with this team if there's specific additional questions. I think it's a tremendous opportunity for us as academicians to be engaged in this research. It's honestly, it's not the type of research I do, and I kind of signed on as somebody senior to kind of be part of this, but I have no dog in this fight. I'm happy to hand off and allow people to kind of flourish in this space.
VK, I don't
Wonderful.
know if you've talked to Pam yet. I have a contact in palliative care at Rush who has contacts at Northwestern University of Chicago, Loyola, all the main medical centers. So she's trying to connect the palliative care programs for us so that we can get this program out wide.
That would be awesome.
Yeah, so anyone who has any other leads on connections, you can see how this fits perfectly into this talk because it's about that very holistic care, holistic wellness of not just cancer survivors, but also their children and facilitating relationships like Siavash was highlighting in his talk, is that that's so important to healing. So it's great that this work is going on. So thank you, VK. I know you're traveling, so we should let you go. I know Angelina and I can field any other questions that come up. Thank you for stopping in.
I got it.
Thank you.
Awesome. Does anyone have any other questions about the clinical trial? Angelina, do you have anything else to say about it?
I think Dr. Gotti covered everything pretty well. We've talked to a few different teams, as we mentioned. But if you do find patients who you think are eligible or you have other questions or anything like that, feel free to reach out to me and I can get those patients referred or speak with them as well to give them kind of more detailed information about the study. So, yeah.
Great. Yeah, I'll send out. Again, my list of resources is extensive. After this talk to send out, I'll send out a copy of the flyer for the ECPC study so that everyone in the lecture series group can have that. Anyone else have any other comments? Siavash, any final words? What are your thoughts on this study?
It looks like necessary work. You know, as a father, you know, it's hard for me not to look at people with children who are survivors, who are dealing with, you know, possibly end of life situations, and not seeing myself in them, and feeling that the angst that they must be going through, just because, you know, I'm sure for anybody who's a parent, like everything changes when you're a parent, and your goals and your thoughts and what matters in life changes. So the thought of not being there for my child is hard to stomach. So being able to assist these people, I think is just important work. And so I'm happy that, you know. And thank you for having me. I think this was fun. Like I said, there's a lot of, as my talk didn't have enough of it. There's a lot of kinship between survivorship and palliative care. So we're two peas in a pod. So
I think we'll be going on to strengthen this relationship between the fields, between our clinics and everything. We'll definitely be trying to make tons of palliative care referrals. Take note. We should have this, Neha. Every patient probably should be going to see Siavash and his team. So
the clinic that we have in oncology, the part of the requirements is active cancer, but that's just as FYI. But that's still I'm sure that's a lot of survivor patients. So
good to know. Good to know. Yeah, so making a referral to you guys, just ambulatory referral to palliative care.
Yeah.
Does that go to the right place and you guys?
That's cool.
Okay. That's so hard to keep track of which referrals are going where. So that's good to know. So thank you everyone for attending. Thank you so much, Dr. Azarnia, for telling us about your important work. And if anyone has any questions, just let me know. Otherwise, have a great rest of your week and weekend.
Thank
Bye.
you, everybody.
Thank you. Bye-bye.